Hi, everybody. My name is Dr. Mark Donaldson, and I'm excited to spend the next 45 to 60 minutes with you speaking about what's in your emergency kit, and perhaps even more particularly, what are the 7 essential drugs that every dental office must know. So let's jump into it. Why do you care about this? Well, medical emergencies actually do happen, and they happen quite often when you take a look at the literature. About 2 medical emergencies are experienced by most practitioners for every year that they practice. Now, that may seem like a very high prevalence to you, and part of the reason for that is in our definition of medical emergencies. If I was to rephrase the question and ask you, how many times have you ever had a patient faint in your office? Then I think that would start to elevate the numbers because while most of us do not consider fainting or syncope as a medical emergency, the fact of the matter is that for a very short period of time, that patient actually goes into asystole, where if you could move humanly fast enough to get a blood pressure cuff on that patient, you'd recognize that their blood pressure might drop to 0/0. And then we may have 2 medical emergencies on our hands, you and the patient. So the good news is that you cannot move humanly fast enough to get a blood pressure cuff on that patient. But when you do, you recognize that their blood pressure might be quite low, let's say 80/60. Maybe you think that you've done that wrong, so you redo it, and the next time the blood pressure is closer to 100/80. Still pretty low, but it's moving in the right direction. And by the time you get a third sort of blood pressure reading on that patient, and maybe then it's 120/80, that's usually the point at which the patient's eyes flutter open, and they're back to normal. And none of us truly consider this to be a medical emergency because in most cases we can continue with the dental appointment. The fact of the matter is that we have done hemodynamic studies on these patients, and actually we now recognize that they don't fully recover for up to 48 hours after a fainting episode. So while fainting is fairly commonplace, it really is a medical emergency. And based on the top medical emergencies most often experienced in the dental office, as I said, on average, you will be experiencing a medical emergency about twice a year for every year that you practice. Now, Dr. Stan Malamed, sometimes referred to as the guru in the area of medical emergencies in the dental office, has taken a look at this topic over the years, and as you can see, has distilled it down to the most common medical emergencies that dentists come across. Now, the great news when you take a look at this list, and of course, syncope once again is topping that list, is that all of the medical emergencies that I have drawn a red arrow next to here, those are all of the ones that will disappear. You may never actually experience these medical emergencies when you offer excellent intraoperative local anesthesia combined with anxiety-reducing approaches. So we all know that greater than 50%, that's 50% of the general population, is considered to be anxious or fearful about going to the dental office. And so if we could simply get our patients to relax, whether that's with some TLC in the office as soon as they cross the threshold of your door, or maybe it's with other pharmaceutical interventions, inhalational sedation with nitrous oxide and oxygen, or maybe even oral sedation, anxiolysis with an oral medication such as a benzodiazepine, a Valium-like drug. If we could just get our patients to relax, if we could keep them comfortable with excellent intraoperative local anesthesia and continue that with excellent postoperative analgesia, almost all of these, or at least 75% of medical emergencies, will dissipate. You will never see hyperventilation, angina, the challenge of an asthmatic attack, and others in patients that are pain-free and also anxiety-free. So maybe that's another, let's say, collateral benefit of offering that TLC and sedation practice in your office to mitigate the opportunity for experiencing a medical emergency. One other piece I think is always important, we all learned this in dental school, but that critical time frame for when you may expect a medical emergency in almost all cases is around about the time of local anesthesia administration. You can see that 55% of all medical emergencies occur during or after local anesthesia. So, if you ever want to have a heightened awareness, that kind of is your critical time frame. But again, offering excellent intraoperative local anesthesia, as well as anxiety-free dentistry, tends to set you, your team, but most of all, and most importantly, your patient up for success. Local anesthetic overdose is sort of that non-emergency I just wanted to highlight. Typically, that is when the patient starts to get, a little bit jittery. Maybe you got your injection a little too close to a vessel, and really what you're seeing is that epinephrine reaction in a patient. The good news is epinephrine has a half-life of about 2 minutes. So simply talking calmly to the patient, letting them know what they are experiencing and the fact that it will dissipate very, very quickly turns this sometimes considered medical emergency, but really is a non-life-threatening emergency into something that disappears very, very quickly. So what does the medical emergency kit look like? Well, first of all, your cell phone may be one of the most important pieces or tools in your toolkit, because the right answer on the test is to always call 911. While we are well trained, your staff is well trained, you have an emergency kit, you know how to manage your PABCDs: position, airway, breathing, circulation. D, definitive care, which could be the use of an automatic external defibrillator or drugs. The fact of the matter is, if you want help and you want it there quickly, call the experts. And so you don't see your insurance rates go up. You don't get any points against you by simply calling 911. And so having access to your cell phone really does help get the experts there as quickly as possible. Now, if you are going to call 911, obviously that's not the only thing that we do. We want to jump into our PABCs, as I described. Be prepared to offer CPR or cardiopulmonary resuscitation. We want to make sure our patients are kept comfortable and that we can start that chain of survival until the EMTs arrive. Now, a quick word about automatic external defibrillators, because believe it or not, not every state in the US or every province in Canada currently requires automatic external defibrillators in dental offices, which is a shame, because if we have AEDs in supermarkets, libraries, schools, airports, why would you not have one in a healthcare provider's office? If you take a look at the history over 25 years with the automatic external defibrillators, you can see initially when we only had AEDs in the emergency department, if somebody was to have some type of cardiac event and they were lucky enough to get to the hospital and be shocked with an AED, their survival rate was around about 2%. When the American when the American Heart Association was able to look at this data and start to increase their public service announcements, Good Samaritan laws, and encourage the general public to start to take cardiopulmonary resuscitation or CPR classes, then when you saw somebody go down in the general public, you could call 911, you could start CPR, and getting defibrillated in the emergency room quadrupled the save rate to about 8%. As we continue to improve this continuum over the next 5 years with early CPR, early defibrillation, now putting defibrillators in some of our ambulances and fire trucks, early defibrillation before getting into the hospital led to a 20% survival rate. And where we are today with early CPR, with AEDs in schools, supermarkets, airports, and dental offices, and certainly with early advanced cardiac life support being provided by our EMTs, fire department, and others, the survival rate over this 20 to 25 year time frame, it has gone from up from 2% up to 75% or greater. So this alone should be an encouragement to consider having an automatic external defibrillator in your office, and to make sure that you and your staff are well aware on how to use it. Now, since we are driven by evidence from the medical literature, I love this study from the New England Journal of Medicine because it takes a look at the response time and provision of automatic external defibrillators in some of our most populous states in the US. And you can see our most populous state, New York City, despite having a large population, may not be the best place to have a heart attack, because in this one particular study, the time to defibrillation was actually one of the worst. One of the best places to have a heart attack is actually in an airport. You can see that time to defibrillation was much shorter, resulting in a much higher overall survival rate. But there is one place that may be better. I blanked it out, but let me do the big reveal now, and that is the casino floor in Las Vegas. If you've ever wondered why so many old people go to Las Vegas, it's because it's one of the safest places to be. If you're playing the one-armed bandit and suddenly you have a cardiac event, they have AEDs almost every 50 feet in the casino. Hopefully somebody sees you go down, delivers the shock if it's indicated, and you're able to sit right back up and continue gambling away. So just a few important things to realize, that certainly time is of the essence, and the quicker that we can get an automatic external defibrillator to a patient if a shock is indicated, that certainly increases the overall survival. So the great thing about doing this particular presentation is that your experts already determined and published what the 7 drugs in the essential medical emergency kit for dentists should contain. So the list is printed here. It should be on page 3 in your handout. And it consists of 2 injectable medications, epinephrine and an antihistamine such as diphenhydramine or Benadryl. And then 5 non-injectable medications such as nitroglycerin, a bronchodilator, some form of sugar, aspirin, and historically aromatic ammonia. Now, if you're less familiar with aromatic ammonia, you may remember that these are those sort of glass carpules, usually in a cotton mesh, such that if somebody was to faint or have a syncopal episode, you would crush this underneath their nose, and the fumes from that aromatic ammonia would do one of 2 things. It would either confirm that the patient is no longer responsive, or it would cause them to jump up because you just exposed that patient to one of the most caustic, toxic, noxious chemicals that we have. So a quick word about this list, which was published back in 2010, so certainly getting on in age. While this may have been past tense, may have been the standard of care back in 2010, if you take a look at some of the information now, things are changing. In 2019, the California Dental Association adopted the guidelines or recommendations by the ADA, by the American Dental Association that you just saw. But again, that's getting to be a little bit older, and new information has come to light. So one of the new pieces of information is whether or not naloxone, which many of you know as the reversal agent for narcotics, should be included in the dental emergency kit. And again, going back to our good friend Stan Malamed, who co-authored this with myself and Dr. Jason Goodchild, based on the fact that we continue to have an opioid epidemic, it does make a lot of sense for dentists to have a naloxone in their emergency kit. We'll speak more about that as we go along, but just know that changes continue to come forward. This is some more recent information from 2020, so we're now kind of getting into modern time. In fact, if you take a look at some of the commercially available emergency kits these days, naloxone has already been introduced as an essential medication in these pre-made kits. So really keeping up to date, naloxone should be considered an addition to those medical emergency drugs. Which means that if we're still talking about 7, would we be taking one out? And in fact, I have tried to emphasize that these ammonia inhalants may be on their way out, because if you do have somebody with a syncopal episode under whom you crush one of these ammonia inhalants and waft the odor underneath their nose, one of 2 outcomes is possible. Either nothing because the patient is no longer responsive, or because you just expose this patient to a caustic, noxious chemical, they suddenly jump up and they may even take a swing at you. So if you were to cut open the cotton mesh, you can see that there is this glass ampule containing the ammonia inhalant, and it says right on the package that this is a respiratory stimulant or a respiratory irritant. This is how it works. Unfortunately, because it is a noxious and toxic chemical, it can cause a violent avoidance response. It can compromise a patient's ability to stabilize those individuals who may have suffered a head injury if they've fallen. It can worsen the condition of a patient with airway edema or infection. It can trigger an acute asthmatic attack. It can increase intracranial pressure and can also cause coughing, nausea, and vomiting. In all of those situations, it's starting to sound like you may be making a bad situation worse. And for all of those reasons, ammonia inhalants really should not be part of the medical emergency kit anymore. In fact, as a fun fact, ammonia inhalants were banned by the U.S. Professional Boxing Association back in the 1960s because of concern for head injuries. Now, if you were to take a look at all of the evidence to date, and more importantly, all of the recommendations by authorities in respiratory medicine, believe it or not, ammonia inhalants have never ever been part of any regulatory guideline. Yes, they've been around for decades. Yes, we've always used them. Yes, we've always stored them. In fact, many dental boards have recommended them in the past to be a part of your medical emergency kit. But the fact of the matter is, based on this publication and many others since, they just do not have any clinical utility. They don't necessarily make a bad situation worse and simply indicate whether your patient is still alive or dead, but they don't necessarily do anything good for the patient. So no longer part of your emergency kit. We would take those out and we would replace it with naloxone, the reversal agent for narcotics, which again we'll talk more about as we go along. So this is some of the most recent information that you're seeing. And as we go back to our chart from the American Dental Association back in 2010, essentially we would remove the ammonia inhalants. We definitely want to replace that with portable positive pressure oxygen, which is indicated in almost every medical emergency. And then the idea of naloxone, based on the fact that our opioid epidemic is now into its 25th year, that we definitely want to think about having access to that in case we need to use it in a medical emergency in our dental office. So the ADA definitely needs to update this, but this is still the most recent publication by the ADA, but there have been improvements since. So the first and most important medication, that true life-saving medication, that one where you need to provide to the patient immediately for a type 1 accelerated IgE-mediated anaphylactoid reaction, is epinephrine. This is the one where if you get this drug for the patient, somebody else needs to be calling 911. If you are alone with the patient, you don't call 911 and then give the drug. You give the drug and then call 911. It is that important. This is a true life-saving medication. Now, if I was to ask you what is the difference between epinephrine in this little glass ampule versus the auto-injector you see in the background, the short answer is nothing. They both contain 1 to 1,000 epinephrine. Some of the differences in these dosage forms, though, are based on size. So the little glass ampule actually contains 1 milliliter, which is the equivalent of 3 adult doses. In the case of a true type 1 IgE-mediated anaphylactoid reaction, most adults require 0.3 milligrams or 0.3 milliliters of 1 to 1,000 epinephrine. And since the glass ampule has 1 milliliter, that's the equivalent of 3 adult doses. The auto-injectors, on the other hand, contain a single one-time dose, so 0.3 milliliters of 1 to 1,000 epinephrine. The other difference between these two dosage forms is typically shelf life. The glass ampules typically have a shelf life of 2 to 3 years. The auto-injectors you may see only with a shelf life of every 12 to 18 months. They expire, and so you would have to replace. And then finally, don't forget that while I'm showing you the adult EpiPen in the background, you cannot give the adult dose to pediatrics and you cannot give the pediatric dose to adults. So if you treat both adults and pediatrics, you would need to have the pediatric dose, which is half the adult dose, 0.15 milligrams or 0.15 milliliters of 1 to 1,000 epinephrine. This little glass ampule then containing 1 milliliter of 1 to 1,000 epinephrine is the equivalent, as we said, of 3 adult doses or up to 6 pediatric doses. The last difference between these two dosage forms is probably cost, but I don't really want to make this conversation today about cost. I really do want to make it about safety, efficacy, and we'll talk about the economics as we go along. Now, for completeness in your handout, I've given you all of this additional pharmacological information. I think the important point to realize, though, is if you provide epinephrine to a patient and you've gone ahead and called 911, don't be surprised if you need to re-administer epinephrine to the patient after about 5 or 6 minutes, because the half-life of epinephrine is only about 2 minutes. And so many patients, definitely if they are a hypo-responder, might require a second dose. So that begs a question as to how many doses of epinephrine should you have. This is a Gaussian curve or population graph, which starts to drive home kind of the thinking along these lines. Obviously, if you treat patients in your office, you're going to need at least 1 dose of epinephrine. If you happen to treat pediatrics, then you're going to need at least 1 adult and 1 pediatric dose. Because the half-life of epinephrine is only about 2 minutes, if you do need to redose patients, well, then maybe you need to have 2 adult and 2 pediatric doses. If also you happen to live a little bit further from the EMTs and they might not get to your office within, let's say, 10 to 12 minutes, or if you have patients that are genetically predisposed to being hypo-responders, it's quite possible a 3rd dose may be indicated in some patients. So what am I really telling you? That to be truly prepared for a medical emergency, in the case of a type 1 IgE-mediated anaphylactoid reaction, you may need to have 6 doses of epinephrine available if you treat both adults and pediatrics. And if now we're talking about auto-injectors that are having to be replaced every 12 to 18 months, that can start to be a little bit expensive. But, you really can't put a cost on a human life that way. It's just important to think, at least in the background, about some of the challenges associated with these different dosage forms. What about safety? These auto-injectors are supposed to be so safe that even a child can use them. Well, they all have the same the same design. That was the design that was approved by the Food and Drug Administration here in the United States, the Health Protection Branch in Canada, and other regulatory bodies in other countries. And so they all look exactly the same. They tend to have kind of one end where a cap exists. What you see here is a blue cap, and it even tells you right on the dosage form, the first thing to do is to remove the blue cap. At the other end, you will see some type of colored button. In this case, the button that you see here is kind of an orange button. So very quickly, you're able to easily remove the cap. You can see that the cap is covering a hole. And no doubt that is probably where the needle comes out, which is why there was a cap covering it. And so the dosage form, the auto-injector, fits very easily in your hand. Your thumb almost automatically goes over that orange button, and then you want to swing at a 90-degree angle and inject that drug into the vastus lateralis. That's the largest muscle in the body, the thigh muscle, such that epinephrine is quickly taken up by the very rich capillary bed underneath the vastus lateralis, traveling up to the heart and saving the patient's life. The challenge when you do this, however, is that you actually may end up going to the hospital also because you have just injected yourself with epinephrine. So let me go back again and explain here. These products, these devices were all approved based on a singular format. And that singular format is to remove the cap. And while that cap is covering a hole, that is actually not the hole that the needle comes out of. The needle comes out of the other end, which is usually where that colored button is. And in the heat of battle during a medical emergency, you may not recognize that pulling off the cap is not the end where the needle comes out. And so putting your thumb over that little button once you've pulled the cap out and trying to inject it into the patient could result in this auto-injection or self-injection with an auto-injector. Now, some of you might be thinking, well, this is very unusual. Maybe these are just pictures off of the internet. I can tell you that in some cases, these are friends of mine, high-level practitioners who actually teach on medical emergencies. And in fact, because of this design flaw amongst all of the currently available auto injectors, during a medical emergency, you may forget exactly how to inject this, and it's quite possible to unfortunately cause self-injection with these auto injectors. So very important that you know blue to the sky, orange to the thigh in the case of the auto injector that I've shown you here. It's not just a handful of individuals every year. In fact, that allied healthcare professional group, nurses, who give more injections than any other healthcare group in the world, suffer the pains of self-injection by these auto injectors due to a design flaw. And it's reported in not only their journals, but also the highest level of medical evidence, which is a meta-analysis or systematic review. You can see the title of this one: Hazards of Unintentional Injection of epinephrine from auto injectors, occurs hundreds of times every year in this country due to a design flaw. So while the auto injectors are certainly formulated to be so simple, even a child can use them, recognize that they do have some safety issues associated with them. And will somebody ever build a better mousetrap? Well, the good news is that there is a new auto injector out there. This new auto injector has a completely different shape and scale compared to the auto injectors, such as the EpiPens you see in the foreground. And this new product is called AviQ. So I'm sorry about that. AviQ is about the size of a pack of cards. And the nice part about it is that it actually talks to you. So the very first thing you do, again, is you remove the cap. And as soon as you do that, it will tell you which end to press against the patient's thigh. And then more importantly, instead of having to inject the patient for up to 10 seconds with our traditional auto injectors, the AviQ only requires a 5-second injectable into the patient's vastus lateralis to save that patient's life. So it speaks to you, tells you exactly how to deliver the life-saving medication, and again avoids the potential self-injection by an auto-injector because of this new format. So definitely something that you want to look at as an alternative to our traditional EpiPen auto-injectors. Now, some of you may have read the fine print here, and the fine print seems to indicate that epinephrine can be given sublingually to patients that suffer a cardiac event. And I know it says it very, very specifically there, but please know, even as oral healthcare providers, while we understand the anatomy, physiology of the oral cavity very, very well, the term sublingual is not meant to indicate a sublingual injection into the mouth. Here it is blown up just to show you that while it does say sublingually, what this is referring to is actually a sublingual tablet of epinephrine, but that is only available in Europe. So we do not have sublingual epinephrine tablets currently available in the US. So do not misinterpret this statement as meaning you could give epinephrine as an injection under the tongue to save a patient's life. Studies have clearly shown that epinephrine, when injected, is only successful in saving a patient's life as an injection into the vastus lateralis, the thigh muscle. Only then can you get blood levels up high enough and fast enough to save a patient's life. Certainly not as an injection in the mouth. Sublingually here, once again, refers to clinical trials that were done in Europe where they have a sublingual tablet of epinephrine. What is new with epinephrine? Well, something very exciting has recently happened, and that is that there is a brand new intranasal spray of epinephrine. So another advancement in this area to help us, again, avoid potential needle sticks, to help us avoid potential design flaws with the auto-injectors, to help us avoid potential self-injection due to these auto-injectors. This brand new product is called Neffy, N-E-F-F-Y. There were 4 pivotal trials that brought this new dosage form of epinephrine to market. And in each one of those clinical trials, they were able to show that the intranasal delivery of epinephrine got blood levels up higher and faster than the than the injection of epinephrine typically given with our auto injectors. So lots of benefit here. Keep your eye on this one. I would predict over time that if we do want to get away from the traditional injection of epinephrine, that this new intranasal device will replace those auto injectors over time. It was an announcement at the end of 2024 about the approval of neffy by the FDA. And lots of good news around about this from a safety standpoint. You've seen now from an efficacy standpoint, but some additional benefits also relate to the stability of the molecule. We talked already about how the auto-injectors differentiate themselves from other dosage forms in that they have a very short shelf life. Every 12 to 18 months, you may need to replace those. Well, this new intranasal formulation has been shown to be stable for at least 30 months. And more importantly, if you live in areas of the world that have extremes of temperature, whether that's up to 122 degrees, or let's just say that you accidentally left your intranasal epinephrine in a car during the summer, and the inside temperature of the car got up to 120 degrees, or if you lived up north and left your intranasal epinephrine outside and it got frozen. In both of these cases, simply thawing out and administering the accidentally frozen neffy, or giving the drug even when heated up to 122 degrees, provides safe and effective doses. So lots of great information here around about a brand new dosage form, which I'm very excited about. I spent the most amount of time on that one drug because epinephrine truly is the one life-saving medication in the dental medical emergency kit. In the back half of our conversation, then, let's talk about the other 6 drugs. So that second injectable medication, as I said, is usually an antihistamine, and not an oral antihistamine, not like the oral capsules or tablets you see here, but it has to be an injection. And this is typically for those patients that have a histaminic reaction. And I oftentimes get asked the question, well, Mark, what differentiates a histaminic from an immunological type allergic reaction? And it's very easily defined as airway, airway, airway. Anytime the patient's airway is compromised, you want to get epinephrine into that patient as quickly as possible and call 911. But if you have a reaction, such as this individual here, this young child whose upper lip has swollen up due to this histaminic reaction, airway is not compromised, still can breathe properly, no challenge there, but maybe this feels a little itchy or feels a little funny, that's a histaminic reaction. And so giving an intramuscular injection of an antihistamine such as diphenhydramine, typically into the deltoid muscle, would be indicated here. Similarly, another patient that we saw where one half of the lower lip has swollen up, exactly one half on the other side of the midline there. Again, no airway compromise whatsoever. Go ahead and give an injection of the antihistamine, and in both of these cases, continuing with dentistry if the patient is comfortable is perfectly fine. Now, what will typically happen after the dental appointment here is that these patients should go from your office to urgent care or the emergency room to be checked out by a physician. The physician may decide that this patient needs an additional course of corticosteroids, so maybe an injection of Solu-Cortef, Solu-Medrol, maybe even some oral prednisone for a few days, or they may decide that the patient simply needs a 72-hour supply of an oral antihistamine just to make sure that there's no recurrence. Again, oral antihistamines are not part of your emergency kit, but if they are indicated, that would be the decision of the physician that's following up on your patient. Again, for completeness in your notes, I've given you the pharmacology as well as the potential adverse effects and the usual adult doses, again, 50 to 100 milligrams as an intramuscular or deltoid injection. The swelling that we've seen in these 2 cases goes down very, very rapidly. Again, between you and the patient, you can decide if you want to complete the dental appointment, and they should really go from your office to urgent care or the emergency room for full checkout. The next one is nitroglycerin. So we're now starting to talk about some of those patients that have cardiac issues, even more specifically ischemic heart disease, IHD, what we used to call angina. Now, if you remember your cardiac pathophysiology, that all-important organ we have, the heart, has its own microcirculation, the cardiac circulation. And if you get some type of mismatch between oxygen supply and oxygen demand in the coronary circulation, the downstream effect is is the pains of angina. Patients may feel like they have an elephant sitting on their chest, or that clutching sensation. And the immediate drug that we want to give these patients is something called nitroglycerin. Nitroglycerin is a very potent coronary vasodilator. What it's going to do is it's going to open up the coronary circulation. It's going to re-equilibrate that balance between oxygen supply and oxygen demand, and the pains of angina will go away very, very quickly. Now, if a patient who has a history of angina comes to your office and the stress of dentistry brings on the pains of angina, in almost all cases, they have their own nitroglycerin to self-administer. If they didn't bring their nitroglycerin and you think that the stress of dentistry could bring on an anginal attack, you probably want to make sure you go and get your nitroglycerin from your emergency kit and just have it on standby in the operatory before you see the patient. Now, if it turns out that a patient with a history of angina does experience the pains of angina in your office and you feel compelled to give nitroglycerin, you need to ask all of your patients one important question, and that's whether they have had a phosphodiesterase 5 inhibitor in the last 24 to 48 hours. Now, very easy for me to say. So what are we really talking about? Well, at the end of the day, it's Viagra. If any of your patients have had Viagra in the last 24 hours, or Levitra, or what is sometimes referred to as the weekend Viagra, the long-acting Viagra Cialis in the last 48 hours, you cannot give nitroglycerin. So let's play this out for a quick minute. If you don't know the history behind Viagra, it is a phosphodiesterase 5 inhibitor. It was brought to market as a blood pressure reducer, an antihypertensive product. It just turned out that it had one much more marketable side effect, and that's where the erectile dysfunction market suddenly came from. And so we started with Viagra, we now have Levitra, we now have Cialis, we have many, many more of these phosphodiesterase 5 products available to us. Knowing how these drugs work, if a patient has ischemic heart disease and suffers the pains of angina, before you give nitroglycerin, you need to make sure that they have not had Viagra, Levitra in the last 24 hours or Cialis in the last 48 hours. If they have, and you go ahead and give nitroglycerin, the combination of those two antihypertensive drugs is enough to lower that patient's blood pressure such that they cannot sustain their vasculature and they could die. There have been 14 deaths in the United States due to this very significant drug interaction. So we definitely want to avoid that. If a patient has had a phosphodiesterase 5 inhibitor in the last few days and they suffer the pains of angina, you're calling 911. They will go to the emergency room. In the emergency room, we will give them nitroglycerin, but we will also give them some pressor agents and fluids, and they'll survive very well. Now, I keep saying all of your patients. So some of you may be wondering, well, don't you mean just half of my patients, Mark? I mean, why would females be taking Viagra? Well, the fact of the matter is, because these drugs historically have been blood pressure reducers, they continue to be used as agents for treating pulmonary hypertension, which is unfortunately a disease that a lot of females get. So we do have a lot of females on a version of Viagra, not necessarily Viagra, but in this case, it could be a product called Revatio, which has the exact same active ingredient, sildenafil. At the bottom of this slide, you can see some of the other newer antihypertensive or anti-pulmonary hypertensive drugs that are out there. And so again, these would all be contraindications to patients receiving nitroglycerin. And if patients did have the pains of angina in your office and you want to give them nitroglycerin, if they've had any of these products in the last 24 to 48 hours, you should be calling 911 and not administering nitroglycerin. Hopefully I've made that clear. This is just another example of what Revatio looks like. It has the same active ingredient as Viagra, which is sildenafil, so there is a high opportunity for a drug interaction with nitroglycerin. Now, when I say nitroglycerin, it usually comes in one of two formats. It typically comes as tablets. The tablets come in this glass amber vial, and if you ever open that glass amber vial just for a second, maybe to make sure that the pharmacist didn't rip you off, as soon as you close it up, you need to write the date on that, and within 30 days, throw out whatever remains in that and replace it with new stock. And why is that? Well, these tablets are hygroscopic. They pull moisture in from the local environment, and that causes very rapid degradation. Even just opening that bottle for a quick second and closing it, within 30 days, you need to replace the entire contents. They are in a glass amber vial to protect them from light, and they're usually kept very well sealed. So what does that typically look like? Well, if a patient in your office has the pains of angina, doesn't bring their own tablets, you put a tablet under their tongue if they experience the pains of angina, and usually within 2 minutes, the pains of angina go away. If it doesn't, you give them a second tablet, and if it still doesn't after another 2 minutes, you can give them a third tablet. If after 3 tablets, the pains of angina still are present, you're going to call 911 immediately, because this is actually diagnostic of the patient having a heart attack. So you can receive up to 3 doses of nitroglycerin within 6 minutes, but if the patient still continues to have the pains of angina, they may be having a heart attack and you need to call 911. One other scenario that I will play out for you is if the patient in your chair with a history of angina has the pains of angina because of the stress of dentistry, and they tell you, hold up a second, doc, let me just take my nitroglycerin, I got a little touch of anginal pain here. They take a dose and nothing happens. Give me another second, doc, let me just take a second dose here. If they take a second dose and nothing happens, before they take a third dose, what you want to do is go and get your tablets and give them your tablets as that third dose. Don't be surprised in this scenario if your tablet works. You go ahead, finish the dental procedure, and they really should go from your office to the pharmacy, because more likely in this scenario that I'm painting for you, patients don't throw things out. And while you very specifically need to replace all of your nitroglycerin tablets within 30 days of opening it for the first time, despite our best efforts in counseling patients, they just never throw anything out. So more than likely, their tablets, are no longer effective. The other formulation which you see here is a nitrolingual spray, and this nitrolingual spray is an excellent formulation of nitroglycerin. Unlike the tablets, this is not hygroscopic. It has a pretty long shelf life, lasts about 2 years. There's about 90 doses per spray. The only thing you need to know about this particular dosage form, though, and this is critical, is that it is a pump, and that pump needs to be primed. So if you happen to have a patient with a history of angina and the stress of dentistry brings on the pains of angina, if they didn't bring their spray and you go and grab your spray, what you need to do is shake, 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 and then press that actuator maybe 10, 20, 30 times until you see a spray, a mist. And once you see that spray, that mist, go ahead and deliver nitroglycerin as a spray underneath the tongue. Similarly to the tablets, if the patient still has anginal pain after 2 minutes, you can re-administer. If after another 2 minutes they still have the pain, you can re-administer. But if they're still having anginal pain after 3 doses, once again, diagnostic of a heart attack, and you want to be calling 911. So critically important. This is usually that one place where, in the heat of battle, we want to go save a life. You grab the nitroglycerin, you go to spray it in the patient's mouth, and just know that for the first few sprays, the first few pumps, all you're doing is blowing air into that patient's mouth. So critical that if you are going to be delivering nitrolingual spray to a patient, that you prime the pump by hitting the actuator, and only once you see a spray, you go ahead and provide active drug to the patient. Again, for completeness in your notes on page 7, these are the uses, the pharmacology, and the doses, potential adverse effects, but these are very, very rare, and in almost all cases, much more important that you actually get the right drug to the right patient as quickly as possible. If the patient is unresponsive to those 3 doses of nitroglycerin, either as tablets or the spray, or in a patient who does not have a history of angina, ischemic heart disease, and experiences that crushing sensation like, oh, feels like I got an elephant sitting on my chest, we are not taught to do this, but a clenched fist over the chest is something that almost all of us will automatically do if we are having a heart attack. And so anytime you see a patient suddenly, bend over with a clenched fist over their chest, that's 80% predictive of them having a heart attack. It's actually more specific and indicative, sensitive than the enzyme test that we will do in the emergency room if that patient is brought in. So the right answer anytime somebody does that is to call 911, call 911, call 911. We need to get help there as quickly as possible. We don't do what it says in this cartoon, heart attack, walk it off, you pansy. In medicine, we say time is muscle. If you again remember your cardiac pathophysiology, a heart attack means that there is some type of blockage in the coronary circulation, which means that the downstream effect is a lack of blood, oxygen, and nutrients to that part of the heart. And if you don't get rid of that blockage, then that part of the heart will die, and we cannot resuscitate dead tissue. So we want to call 911, call 911, call 911. And then while we're waiting for the EMTs to arrive, we want to jump into our PABCDs. We want to position, keep the patient comfortable, airway, monitor it, breathing, assist if they stop breathing, check pulse, monitor blood pressure, keep the patient comfortable. But most importantly, you want to get aspirin into them as quickly as possible. So aspirin is the next drug in the medical emergency kit. And the importance here is at least 325 milligrams of aspirin. If you carry the baby aspirin, the 81 milligram form, then you would have to give patients at least 4 of those. But the correct answer after you have called 911 is to get patients to chew at least 325 milligrams of aspirin. You need to do it quickly because some of these patients may lose consciousness, and you cannot put anything into the mouth of an unconscious patient. So they chew an aspirin, you continue to monitor, record vital signs, and be prepared to administer CPR. I've put one small term down there, which is MONA or MONA. We don't do MONA anymore. So the American Heart Association no longer recommends morphine, positive pressure oxygen, nitroglycerin, and aspirin in managing our heart attack patients. You want to call 911, you want to get them to chew an aspirin, and you want to get them to the hospital as quickly as possible. Nothing really exciting to tell you about aspirin, acetylsalicylic acid, or ASA. It's been around for decades. But just again, know that the dose is important. If you want to give more than 325 milligram tablets, that's fine. Just don't give less than 325 milligrams, which means that if you only have the baby aspirins, you have to give patients at least 4 of those. Chew and swallow as quickly as possible. Aspirin acts as a fibrinolytic agent, which means it's going to begin the process of breaking down that clot that is stopping the flow of blood, oxygen, nutrients to that part of the heart. Please remember, too, that half the population is different. While many of us will have a clenched fist over the chest, studies have shown that women do not respond to a heart attack the same way as men. In fact, prior to the heart attack, 71% of females said that they felt unusual fatigue, 48% said they had sleep disturbances, and less than 30% actually had chest pain. In fact, during the acute myocardial infarction period, about 43% didn't have chest pain. So anytime you have a female friend, relative that says, I don't feel well, I've got this increased indigestion, anxiety, weakness, unusual fatigue, get them to a hospital as quickly as possible. They may be having a heart attack and they do not present with that clenched fist over the chest. So critical that we get these patients to the hospital as quickly as possible. The next most important drug in your drug kit may be portable positive pressure oxygen. And I'm going to emphasize portable because medical emergencies don't always happen in your office. So you might have to have one of these E-type cylinders on your cart with a bag valve mask in case somebody goes down in the front part of your office and you need to get there and deliver portable positive pressure oxygen to them as quickly as possible. The only thing I can really tell you about this is please remember that all tanks leak. And the reason that I'm emphasizing that all tanks leak is because we've found out, unfortunately, that all tanks leak. And this was brought forward to me by a attendee at one of my courses who came up at the break and said, I want to tell you about a medical emergency I had in my office last week. I said, absolutely, what happened? He said, well, a patient went down in the front office. I practice all the time with my team, so I grabbed my kit, my portable positive pressure oxygen. I went there and I got everything hooked up. When I turned the oxygen tank on, though, nothing happened. I said, this doesn't sound very good. He said, no, I'm a belt and suspenders kind of person. I had a second tank. I went and grabbed it, hooked it up, turned it on. And about that time, the EMTs came through the door and we saved a life. Everything's great. I said, well, it's a great case. Thank you for telling me. And he said, no, you don't understand. At the end, when all the dust settled, I went back to that first tank and it still said full. I check every month. My extra tank of oxygen is always full. My emergency tank of oxygen is always full. And he said, then I tapped the indicator light, and after a second, boom, that arrow dropped. So the arrow actually got stuck in the full position. So don't just take a look at your tank reading every week, every month, however often you do it, and say, yep, it's full. Yep, it's full. Actually crack the cylinder. Make sure that you continue to have portable positive pressure oxygen in your tank because unfortunately all tanks leak. So very important. Remember too that the utilization of a bag, valve, and mask is probably most ideal because without portable positive pressure oxygen and simply a bag, valve, mask, you are only providing room air, which only has 21% oxygen. If you use oxygen with no reservoir bag, you can only really get up to about 60%, but with a bag, valve, and mask, you actually are very easily able to deliver 90 to 95% portable positive pressure oxygen to patients while you're waiting for EMTs to arrive. Number 6 out of the 7 is going to be our albuterol inhaler. This is a bronchodilator. Brand name is typically Ventolin. And not a lot I can tell you about this dosage form other than it has 3 parts. The first part is the dark blue, which is the mouth cap. So you're going to remove that cap. You're going to shake the boot, which is the light blue color, as well as the cylinder, which contains the drug. And after you've shaken it, 5 or 10 times, you then try to coordinate the patient who is having an asthmatic attack, putting their lips around the mouthpiece while you press down on the actuator, and it will deliver a mist of drug through the mouthpiece into the patient's lungs and will break that asthmatic attack. The challenge for us is really in trying to coordinate this while a patient is having an asthmatic attack. And so my recommendation is for you to get an aero chamber or a spacer device. You can see examples of them here. Essentially what they are is a plastic tube with 2 one-way valves at either end. And so you simply take off the mouthpiece, attach that the mouth guard. You attach that end to the spacer device, and then you can go ahead and hit the actuator as many times as you like. The drug will dissipate into the aero chamber itself. Then you simply pass the aero chamber to the patient, and at their leisure, you can see in the top right-hand corner, they simply breathe in and out normally until that asthmatic attack is broken. So much more easily able to deliver this bronchodilator to the patient without having to coordinate the patient's inhalation with you pressing down on that actuator. Again, for completeness in your handout, most of these patients will bring their own rescue inhaler. They'll keep it at chairside in case the stress of dentistry brings on an asthmatic attack. And since it is relatively commonplace for these patients, in many cases you can continue the dental appointment once the patient is comfortable. The typical pharmacology and uses are listed here. And then the dose, while it does say 2 puffs every 2 minutes to a maximum of 20 puffs, I will tell you the respiratory therapists at most institutions will try to press that actuator down 20-30 times within a minute to break that asthmatic attack. It's very, very effective. You are not going to overdose somebody on a beta-2 agonist, and the key here is to break that asthmatic attack as quickly as possible, get the patient comfortable, and as I said, in many cases you can actually complete the dental appointment. Finally, drug number 7 is going to be some form of sugar, glucose for hypoglycemia. This is a case where Coca-Cola may be the real thing, because the other ADA, which is the American Diabetes Association, actually recommends a non-diet carbonated beverage as the drug of choice for elevating sugar levels that get too low, causing hypoglycemia. Now, if you're from the Pepsi generation, that's fine. You can give a patient Pepsi, but it just can't be Diet Pepsi. It has to be a non-diet carbonated beverage. The carbonation will open both sphincters very rapidly, allowing the liquid sugar to get down to the small intestine where it's absorbed very, very quickly. Certainly, this is an advantage over the cake frosting many of us trained about. The new pharmaceutically elegant formulation of cake frosting is Instaglucose, which certainly you could give. But the American Diabetes Association, again, recommends a non-diet carbonated beverage. The last product in the bottom here is the intramuscular form of sugar called glucagon. That should not be part of your emergency kit. We're not giving glucagon to our patients that suffer a hypoglycemic event. Now, the challenge with hypoglycemia, we mentioned at the beginning of this course that about 50% of the population has some measure of fear or anxiety about going to the dentist. And so we will offer our patients nitrous oxide or an oral sedative to get them to relax. And when patients are relaxed, they might appear confused, they might seem drunk, they might have some slurred speech, and that sounds and looks a lot like hypoglycemia. So how do you differentiate the two? Well, while many of you may not have a glucometer in your office, it probably is a great idea to think about something like AccuCheck you see here, or some other kind of glucometer in your office in order to test a patient's blood sugar. Now, your index of suspicion is probably highest as the last patient before lunch or the last patient of the day. Certainly, it's going to be highest in those patients with a history of diabetes or hypoglycemia. But if you are nervous about having to lance the patient's finger, squeeze out a drop of blood, put it on the test strip, and find out what that patient's glucose level actually is in order to differentiate it between good sedation or a medical emergency hypoglycemia, bear in mind that you have access to blood in the sulcus. You could easily take a drop of blood from there. You don't necessarily have to lance the patient's finger. That blood from the sulcus works just as well on the test strip, and within 30 seconds can tell you very, very quickly and accurately whether you have good sedation or whether your patient needs some form of sugar to reverse this hypoglycemic event. Now, part of the reason I wanted to almost close with this is because I used to ask practitioners, do you have diabetics in your population? And the short answer was, yeah, I have a couple. Well, I know that today that number is even higher. And there's no point in asking the question. I know you treat diabetics because the Center for Disease Control and Prevention back in 2010 predicted that as many as 1 in 3 U.S. adults could have diabetes by 2050. So we know that that number is growing. And unfortunately, the increasing rate of diabetics in our population is closely assimilated with the obesity epidemic that we have. Because of that, the CDC actually updated their prediction, saying that by 2050, 50%, that's half of all Americans, will have prediabetes or diabetes. So for this reason alone, I would greatly encourage you to consider getting a glucometer in your office. And not that you have to diagnose diabetes, but you should be able to use it as a screening tool to again interpret whether or not you have good sedation or whether your patient is having a hypoglycemic event that may require some medical attention. So do you have a glucometer? Do you want to use a glucometer to avert medical emergencies related to diabetes? I walked around CVS the other day. Glucometers typically cost less than $20, so not a large capital investment for dental offices. You are going to be seeing more and more of these. If you would like a more accurate point of care test, again, a drop of blood on a test strip, there are hemoglobin A1C point of care tests out there as well that you could get. Gives you a much sort of longer snapshot as to the patient's glucose control over the last 90 days. But really, you should have a glucometer. We're going to be seeing and treating more and more diabetics, so being able to tell where they are as far as their glucose control is going to be very important. And you may not be aware, but there actually is a billing code, a CDT code, which is D0411 for chairside A1C testing. So maybe not a huge revenue stream, but if you need some encouragement, additional encouragement to do the right thing, why not do the right thing? And almost where I started, the 7 drugs that are required in the minimal dental emergency kit is what we covered today. These are some of the ones that we do not have. We do not have an injectable benzodiazepine, such as midazolam or Versed. That would typically be given to somebody that has a seizure, but in the case of seizure, one of 2 things happens. Either the patient has a history of seizures, you know about it. If they have a seizure in your office, you simply keep them comfortable, and you and the team help them avoid hurting themselves or others. Seizures are self-limiting. Usually within 30 seconds it breaks. And if you and the patient decide to continue dentistry, that's perfectly fine. In the second case, where it's the patient's first seizure or they have no history of a seizure, you do exactly the same thing. You and the team keep the patient comfortable, make sure they don't injure themselves or others. And when the seizure breaks, my recommendation is probably, if it's the first time, to call 911 and take them to a hospital. But again, depending on where you are in that appointment, you could potentially finish dentistry, and they could go from your office to the emergency room. Atropine is a ACLS, advanced cardiac life support drug, that we give for patients with low heart rate or bradycardia, not indicated as part of the minimal dental emergency kit. I put it here because some states do require it. California is one where the state dental board in California requires all dentists to have atropine. But if your state dental board doesn't say you have to have it, I wouldn't necessarily carry atropine in my emergency kit. Nitrous oxide, I think it's a great modality. We'll save that for another time, but not required in your emergency kit. And corticosteroids, again, not life-saving drugs. They're typically given to patients that might have an allergic reaction, but that decision, once again, not made by you. It's made by the emergency room physician when that patient that has a histaminic reaction or an immunological reaction goes to the emergency room, and the physician decides then and there. We talked about the hazards of aromatic ammonia. Great news, update on aromatic ammonia. You can't get it anymore anyway, so you really can't carry it. And as I've said, it's never been part of any treatment algorithm. The last 2, flumazenil. If you do sedation in your dental office, you definitely have to have the reversal agent for sedation. So that would be flumazenil, also known as Romazicon. If you don't do oral sedation, meaning that you do not use a benzodiazepine, a Valium-like drug to relax patients, then that would not be part of your kit. But I'll close with one of the most recent updates, and that is this idea again of naloxone or Narcan. So we've had the opioid epidemic amongst us since 1999. And while dentists do not typically utilize narcotics in your office, because once again, this high level of anxiety or fear in the general population, you may have situations where a patient self-medicates. They might have some Tylenol 3s, Percocet, Lortab, Vicodin left over from an old knee operation, or they take some type of narcotic, illicit, and they don't tell you. So because of their dental fear, they take something to take the edge off. They come to your office, and you might decide to give them an oral sedative, something like Valium, Triazolam, Lorazepam. That interaction between the narcotic they took but didn't tell you about and your otherwise safe sedative could get them into a much deeper level of sedation than you intend. Now, if the patient does become unresponsive, the only thing you did differently was give them an oral sedative, so let's reverse that with flumazenil. But if nothing happens, then the next thing you probably want to do is call 911, and if you have it, provide that life-saving drug naloxone. So that's the reason for naloxone in your emergency kit, not to reverse any type of narcotic that you may be using. There's really no reason for dentists to provide narcotics in office, and certainly not for post-operative dental pain as first-line therapy. But given the backdrop of our opioid epidemic, it makes the most amount of sense to have naloxone in our offices because, let's face it, it has been deregulated. It is now available over the counter. You can see it comes in many different formulations, and while we used to historically give it as an injection, This brand new intranasal formulation helps to avoid potential needle sticks and is very easily given to an unconscious patient simply by spraying it up the nose. The FDA, as I mentioned, has deregulated Narcan based on the prevalence of the opioid epidemic. And so you can literally get Narcan over the counter now, or even out of vending machines without a prescription. And so why would you not take that opportunity to have this life-saving drug in a healthcare provider's office? We mentioned too that most of the pre-made kits will typically contain naloxone now, so that has been an excellent upgrade. And if you are putting together your own kit, just know that naloxone certainly would be considered an essential medication to add to the minimal dental emergency kit. So I want to thank you again for your time.